Welcome to our sepsis lesson. The purpose of this video is to provide you with real-world nursing education that goes beyond just our nurse workbook alone. So getting into one of the most important conditions that we have as nurses at the bedside is our sepsis. And there's a really big reason why hospitals put so much money into this whole sepsis workup and sepsis education. Because if sepsis isn't recognized and managed appropriately, the risk of mortality increases significantly. So there is infections and then there is sepsis, and sepsis can be so dangerous, which we're going to get into. But there's one thing that we need to get into before we deep dive into sepsis, and that is our SIRS, or our systemic inflammatory response system. So this is when there is this overwhelming response in our body from something like a pancreatitis or some ischemia from burns or maybe even trauma. So this means that our body has gone into this high alert and it's trying to fix a problem. But the problem is that this response system is going so big and rapidly that it's actually attacking our tissues and our organs. And why do we want to talk about SIRS before we talk about sepsis? Because SIRS plus an infection is actually sepsis. You guessed it. And we define sepsis by 3 different stages, and that's what we're going to hop into now. So we're going to start out with our basic level of sepsis. And this is when a patient is going to have 2 of the following symptoms plus a source of infection. So we can see an elevated lactate greater than 2, and this is because an elevated lactate in sepsis is a sign of tissue hypoxia. So this means there's a reduction of blood flow and oxygen to our tissues. And then we're going to see this SIRS criteria we just talked about, where we're going to have an elevated heart rate, we'll have an elevated respiratory rate, but typically we're going to see a low blood pressure. And this is going to be due to that vasodilation that this cascade is doing. So the capillaries in our vessels are going to start to become leaky, and this is that wide vasodilation going on. So this is going to cause that low blood pressure. And then we'll have a need for our supplemental oxygen, because as you can imagine, if our capillaries are leaky, that means even what's happening in the alveoli is also leaky, and we're going to have a really bad gas exchange present. We can also see blood clots develop in these leaky capillaries that can lead to this purpuric rash that is an indication of ruptured blood vessels. And if sepsis starts to progress, this is going to lead us into severe sepsis. So this is when we're going to see our symptoms that we just talked about from the left column, plus signs of organ damage or dysfunction. We're going to continue to see that elevated lactate, but our patients may have an altered mental status, and that's mostly because they're going to be lacking oxygen to the brain. So if you're lacking oxygen to the tissues, you're most likely going to be lacking oxygen in that brain as well. We might even see an acute kidney injury. And we could always see that respiratory failure, our ARDS going on. And if we remember from our ARDS lesson in our respiratory module, that whole ARDS cascade was the same thing, that leaky capillaries going on, making a terrible gas exchange inside our alveoli. We can also see an elevated troponin. And troponin is a sign of muscle breakdown, so this is not surprising. We could see a new or worsened elevation of our liver enzymes, and our urine output is going to start to decrease. And this is because our kidneys aren't doing a very good job of filtering all of this infection or not getting enough oxygen to do their job as well. And this is because our kidneys aren't doing a very good job of filtering urine, but they're also under so much stress from this whole inflammatory response system going on. And we can see a new or worsened platelet count that can even be less than 100. This part of sepsis can lead our patients into something known as DIC. And this is disseminated intravascular coagulation. So this can mess with all of our clotting factors and actually end up making it where it's thrown way too many clotting factors out in this response system that now we actually don't have enough, and now we have a whole bunch of bleeding going on with not enough clotting factors present. And if all of this isn't bad enough, we can have something called septic shock. This is where we're going to see all the symptoms we just talked about on these two left columns, but we're also going to be seeing continued hypotension. And this is going to be despite any fluid resuscitation attempt. So this means that our patients are going to need ICU monitoring because they're needing vasopressors because of them being so hemodynamically unstable. And at this stage, the mortality is at its highest risk. We want to make sure that we're continuing our fluid resuscitation. And of course, we're going to get multiple IV antibiotics to try to hit this overwhelming infection and stop this whole SIRS progression. And how do we treat this sepsis? Well, of course, we have the number one rule that we need to draw our blood cultures before we give our antibiotics. And this is because those blood cultures are going to help us get the answer of what kind of pathogen is causing this overwhelming infection. And of course, it's so important to go ahead and give broad spectrum antibiotics. So hopefully it covers whatever this is. But it's better for us to start the antibiotics first, so that way we can always see what the infection is later and know if the antibiotic covered this type of infection or not. So we're not just waiting and letting our patient get sicker without giving them an antibiotic. And how do we treat our sepsis? Well, if sepsis is suspected, then the nurse is going to complete these bundles within the 3 and 6 hour time frame. So anytime we see sepsis present or we think sepsis is present, whether this be on the floor, in the ER, or wherever it is, we're actually going to stop our assessment process and make sure, of course, our ABCs are okay, but we want to complete this whole beginning 3-hour sepsis bundle so we can start to treat this sepsis first, because for every time or hour that goes by that it's not recognized, it's not treated, again, increases that mortality risk for our patient. And once we finish the 3-hour bundle, then we can go ahead and finish the rest of our assessment. So what does the 3-hour bundle look like? Well, this is going to be obtaining that lactic acid. We also want to get those blood cultures before antibiotics, and we want to give those broad spectrum antibiotics. And if our septic shock is suspected from the get-go, we're going to start that 30 mils per kilo bolus for the hypotension or any lactic we see that's greater than 4. And once our 3-hour bundle has passed, we still have work to do within a 6-hour time frame. So at the 6-hour mark, we're going to make sure we repeat our lactic acid, and we want to try to see this number trend downward. We're also going to start our vasopressors if there's any hypotension and continue with our fluid resuscitation. And we're going to document and consider any other tissue perfusion monitoring tools that might be necessary. And if we do not suspect sepsis, we're going to continue our normal assessment. And lastly, we have this condition known as MODS, or multiple organ dysfunction syndrome. So this is the inability of 2 or more organs to maintain homeostasis. And this is secondary to an underlying condition such as our sepsis or trauma. Typically, when patients are at this level, we're going to be giving them renal replacement therapy or maybe have them on a ventilator or mechanical ventilation. This concludes our sepsis lesson. I will see you in the next one.